welcome to today's session where we're going to deal with ACS, diabetes mellitus, in a case presentation format. I'm Professor Robert Welsh from the University of Alberta and the Mazankowski Alberta Heart Institute, and an interventional cardiologist practicing in Canada. These are my disclosures for the last 5 years, dealing with the companies that I've received research support from and honoraria, as well as consulting fees. Diabetes is a major and growing global burden. This is one of the most devastating things I think I've seen in my career, and this slide just shows one of the many different ways of looking at the growth of diabetes, showing the darkening of colors as we pass in time. So this slide, based on 2001, shows a percentage of diabetes listed here on the side, but the message really is the darker the color, the higher the risk, or the higher the percentage of people in that country have diabetes. So if I move through to 2003, you can see an impressive global spread in the incidence of diabetes, and the projected incidence in 2025 is very high, with many countries approaching the range of 11 to 15%. If we go down to the biggest impact for this group we're speaking to today, 6 of the world's top 10 countries for the highest prevalence of diabetes are located in the Middle East and North Africa regions, listed there for your interest. And really, if you look at the incidence of diabetes, it is truly a growing epidemic in these countries, and it's expected that the cost of diabetes specific to these countries will double in the next 10 years at least, if not more. When it comes to cardiovascular outcomes in diabetes, it is very clear that diabetes increases your risk of having cardiovascular events, but it also increases the adverse outcomes during an event compared to a non-diabetic. So if you go back to the full diabetic population, 80% of diabetic patients actually die from cardiovascular disease or stroke. And then if you look comparatively to individuals without diabetes, the cardiovascular mortality of a diabetic is 2 to 3 times higher in a man and up to 5 times higher in a woman, which is a staggering figure. The lifelong risk of coronary artery disease is 2 to 4-fold greater. Age of onset is 10 to 15 years earlier. Life expectancy in diabetics compared to non-diabetics is 5 to 10 years less. And it impacts all of our morbidity, not just our mortality, with increased risk of heart failure, ischemic stroke, future myocardial infarction, and also one of the most compelling things for me personally is mortality post-MI being increased by 2-fold. The other things which are not specifically cardiovascular but are clearly devastating is if you move on to blindness, there's a 40 to 70 times increased risk of blindness or end-stage renal disease in the diabetic population, and then due to the vascular disease, increased risk of amputation as well. So diabetes in general, with this spreading epidemic, is really a crisis for our healthcare system and something we need to focus on improving. If you look at what happens to diabetic patients that suffer an acute coronary syndrome, this is one of several slides, but this is based on a combined analysis of the TIMI trials of 62,000 patients, where they looked at diabetic patients with or without having a STEMI or an NSTEMI. So the red bars, or the red lines on this screen, are the diabetics with STEMI, and the dotted bar is the non-diabetic patients, showing that they have about half the mortality of a diabetic that has a STEMI, and then a similar, although not as high, overall rate in the non-STEMI patients, again with the dotted line in blue this time being non-diabetics, and the solid line in blue being the diabetic population. So just in a figure showing what I stated verbally on the last slide. So let's get on to the case to get us all thinking about the management of these patients. This is a 72-year-old woman. She had complained of episodic burning in the epigastric region for 3 days prior to coming in. The most recent episode had lasted 45 minutes and was associated with diaphoresis. She arrived at a local community hospital emergency room 1 hour after her last episode and was now pain-free. Her past history included hypertension and diabetes, for which she was on oral medications. She had had a prior transient ischemic attack 3 years earlier. Her body weight was 69 kilograms, and I haven't given you her height, but her calculated BMI was 35, so quite excessively obese. Her blood pressure was 140 on 80 with a heart rate of 64 and regular. Creatinine was a 120 with a GFR mildly reduced because of her age and body size, with the GFR being 40. Hemoglobin was in the low normal range at 120 with a normal platelet count. Her presentation ECG showed some subtle ST changes that you can see here. I wouldn't call these diagnostic changes, but in her V2 through to V5 and 6 leads, there's some terminal T-wave inversion, which is a subtle signing and is not diagnostic, but I think with her history you would be compelled to think she's probably going to be an NSTEMI. And then her first troponin level shown at the bottom of this slide was 20, and in the center this was done, that was slightly above the reference, so at this point a low positive troponin. This lady continued to be stable in hospital, but her ECG showed fairly impressive progression at 6 and 12 hours shown here, now having deep terminal T-wave inversion. It may not be completely classic for the Welland sign, which is typical for proximal LAD stenosis, but is very suspicious. So we now have a lady with symptoms, an ECG that looks very concerning, and a positive troponin, suggesting that she has a confirmed diagnosis of NSTEMI. So when I try to walk through management of the NSTEMI patient population, I do it myself in a series of steps. I think the first step in someone with chest pain without diagnostic ECG changes is making a timely assessment and confirming the clinical diagnosis. So you don't want to be treating non-cardiac chest pain patients aggressively, but in this lady it's very clear that she has a diagnostic NSTEMI. Once you've confirmed that diagnosis, you should really assess that patient's short and long-term risk of recurrent ischemic events, but also their risk of bleeding. And once you've done that, it really guides your evidence-based medical therapy, the optimal agents to use, the optimal approach, and obviously looks at impact of secondary prevention to minimize events. And the final bit of that is leading, once you've maximized the medical therapy, the fourth step is moving forward with appropriate either non-invasive assessment if they're a lower risk patient, or invasive investigation and appropriate revascularization in those at moderate to high risk. This is one of the guidelines that I've adapted from work of Chris Cannon. It's published quite some time ago, so I've adapted the agents used in here. But once you're to the point of a strong clinical probability of ACS, really those patients should be started on aspirin, a P2Y12 inhibitor, so that we get dual antiplatelet therapy. Once the diagnosis of NSTEMI is confirmed, you should start anticoagulation, beta blockers, ACE inhibitors, a statin, and nitrates for symptoms early on. In those high-risk patients like we've shown here, which is defined by troponin positivity, ECG changes, recurrent ischemic events, or hemodynamic or electrical instability, our guidelines and evidence suggest you move on to an invasive strategy. In some ways, those are our easy patients to manage because there's a very clear line of how to move forward. In those patients that are lower risk, really the move forward approach is a little more complex. You can observe them, you can watch for recurrent events. If they don't have recurrent events, you really have a choice by the patient's risk profile to move back to the other strategy of an invasive management, or you can observe them, move forward with non-invasive testing and so-called conservative strategy. Either way that you move forward through this list of options, long-term medical therapy has clearly been proven to decrease events in the future. Dual antiplatelet therapy started early and continued for a year. An angiotensin receptor blocker to decrease the risk of recurrent events. Statins have been very clearly shown to decrease recurrent events, and beta blockers important in all patients, but especially important in those with arrhythmias or with left ventricular dysfunction. So if we go back to our case, back to this lady, she clearly has a diagnosis of NSTEMI. I perceived her to have a high ischemic risk and a moderate bleeding risk based upon her age, gender, prior TIA, and diabetes, and a mild renal dysfunction. Initially, she was seen by our emergency medicine colleagues who started her on aspirin clopidogrel, given at 300 milligrams immediately and followed by 75 milligrams daily. And she was treated with the anticoagulant unfractionated heparin, which was chosen again on the emergency room's physician's preference. And then she was referred on through cardiology for an early invasive management strategy due to her high-risk features, with plan to have a cardiac cath within 24 hours. So the question that we deal with our new agents available is, what do you do to optimize this patient's oral antiplatelet therapy at this point in time? When we look at the agents we have available, clopidogrel is shown on the bottom of this graph, which tries to show the metabolism of our different agents available, which kind of puts in perspective how these agents are utilized and their impact on patients. So clopidogrel has a multi-step metabolism. Therefore, because of genetic differences between patients, the effect of clopidogrel is less predictable as well as less potent and has a slower onset of action. So it takes time to get from the prodrug to the final molecule that's actually utilized to block the platelets. Prasugrel is an advance from clopidogrel, has a very similar end molecule, but has less steps to be activated and therefore is more potent, faster onset of action, and more predictable. Ticagrelor is actually not a prodrug like the other two agents. Once you've given the agents and it's absorbed, it's effective immediately or very rapidly. So again, a more potent, more predictable agent and faster onset of action. So the attraction in a patient population moving on to PCI is really to get the therapy maximized prior to the procedure and insertion of the stent. If you look at the trial data that we have to look at these different agents, I'll start on the far right-hand panel. The current OASIS study was a study led out of Canada with double-dose clopidogrel for 7 days, and it was a planned ACS, planned PCI population. The outcomes of that trial overall were neutral, but in the subgroup of patients that moved on to PCI, there was a subtle advantage of a double dosing strategy. If I then move to the far left, the next published trial was Triton with prasugrel, again a more potent, more predictable agent than clopidogrel. We saw a reduction in endpoints, which we'll come back to in the specific diabetic populations, and this was a trial in ACS patients that were actually about to receive PCI. And then Plato study with ticagrelor shown in the middle, first reversible antiplatelet agent that we have, was an all-comer ACS population randomized in the emergency department. The current study shown here does not have a separate diabetic and non-diabetic analysis completed. So what I've shown here is the overall trial results of standard clopidogrel versus double-dose clopidogrel, showing the reduction in ischemic endpoints being non-significant in the overall patient population. But there was a price to pay with double-dose clopidogrel with an increased risk of bleeding, although you can argue modest. The neutral ischemic results, though, make it a fairly easy decision for an all-comer patient population that double-dose clopidogrel has a mild but non-impressive benefit. If you then move into the Triton study, now looking specifically at those with or without diabetes, the diabetic patients shown in the left-hand panel have an impressive reduction of about 5% in the composite endpoint, showing the benefit of rapid, more potent, more predictable agent. And the price to pay, the non-diabetic patient populations also had a significant benefit, but a less impressive overall result. And then the TIMI major bleeding is shown on the bottom here. The diabetic patient population, although they are clearly exposed to increased ischemic risk, do in this analysis, plus in many others in the past, not appear to be exposed to the same bleeding risk, which is an interesting discussion point. If we then look at the results we have from the Plato trial, shown differently because this is how the investigators presented the data to us. This is now ticagrelor versus clopidogrel with a background therapy of aspirin in these two groups. The diabetic patients again have an overall higher risk exposure on the primary endpoint, shown on the upper left-hand panel, and the non-diabetic patients shown, both of which are consistent with the overall trial results. But the thing that makes Plato intriguing and most interesting is this very impressive reduction in all-cause mortality in the diabetic patients, approaching a 2% absolute reduction in all-cause mortality, a very impressive result. And then if you look at bleeding, again, there is no clear signal of increased bleeding in the diabetic patient population compared to the overall. So I think a very attractive agent in terms of the all-cause mortality benefit with ticagrelor in the Plato study. So what do we think about when we try to treat these patients? We have to be careful with any anticoagulant and antiplatelet strategy to balance the risk of bleeding with the risk of recurrent events. So we have to play those two off against each other. But in the vast majority of patients, the ischemic risk is 10 to 100 times higher than the risk of fatal bleeding. So we need to focus on that as we move forward. Other factors that influence the risk of bleeding and make us choose our agents more carefully is renal function, obviously signs of bleeding risk through platelet count, existing anemia, and then the timing of our invasive procedure. If you're moving on to the cath lab, you do want to have an effective agent on board at the time of PCI, as well as previous medical therapies. If someone came to you on clopidogrel and had a recurrent event, switching to one of the new agents would be a very attractive strategy. When we look at the impact of diabetes on patients' risk management, it's very clear that diabetic patients have a worse short and long-term outcome with increased mortality compared to non-diabetics, increased risk of recurrent ischemic events, including heart failure, cardiogenic shock, but also an increased risk of stent thrombosis. The current guidelines suggest that this strategy of an early invasive approach should be utilized in high-risk patients, and pretty much all diabetics approach that group. So we do tend to move to an early invasive strategy in our diabetic patient population. And then obviously with antiplatelet therapy, there's compelling evidence, which I've shown you briefly in the prior slides, that there's benefit of the newer agents over clopidogrel, and then the mortality advantage with ticagrelor. The other thing to stress in diabetic patients is the importance of all the other secondary prevention measures: exercise, weight loss, optimizing hypertension and cholesterol control, as well as optimizing their diabetes management. So let's go back to our patient again. This patient was clearly seen to be high ischemic and a moderate bleeding risk. She was started on clopidogrel and aspirin and unfractionated heparin in the emergency department, but when transferred to the coronary care unit and the decision to go to an invasive strategy was made because of her high-risk status, she was converted to ticagrelor with 180 milligrams given emergently and then 90 milligrams twice a day, and moved on for cardiac catheterization fairly rapidly thereafter. At the time of her cardiac catheterization, the figure on the left-hand panel shows a severe stenosis in the mid-left anterior descending right after a large septal with clot burden present, so we're happy we have a potent antiplatelet agent on board. The rest of the anatomy, just for completeness, which you can't see here, was a small circumflex with only a minor 50% stenosis, and the RCA only had distal irregularities, so no real significant other disease. The left ventricular angiogram showed moderate anterior hypokinesis, and she had successful insertion of a drug-eluting stent in her left anterior descending with no obvious procedural complications. At time of discharge, she was referred to cardiac rehab, which is very important for solidifying our in-hospital care and our secondary prevention through lifestyle intervention. She was given advice to return to work and driving, which varies by country. So I'll leave that to the physicians involved, but it is important to acknowledge the importance of returning to work prescription, essentially, and warning about driving early after an event. And then her prescriptions as she went home and out the door of the hospital was aspirin at 81 milligrams a day, so low-dose aspirin, ticagrelor 90 milligrams twice a day, atorvastatin 40 milligrams daily, bisoprolol 5 milligrams daily, perindopril, and obviously continuation of her prior diabetic management, and she was arranged for follow-up in 4 weeks' time. So as we move on to conclusion and understand the impact of diabetics, hopefully demonstrated through this case, it's clear in all CS patients that we need to risk stratify to understand targeting our appropriate therapy in this patient population. Balancing the ischemic risk and the bleeding risk is important, but we do need to acknowledge as clinicians that the vast majority of the time the ischemic risk is far more important than the bleeding risk, but that is not to downplay the importance of making that assessment. Initiating a P2Y12 receptor antagonist early, in addition to aspirin, has very clearly been shown to reduce ischemic events in patients with ACS and should be started as soon as a diagnosis is made. Compared with clopidogrel, both prasugrel and ticagrelor clearly reduce ischemic events. The new P2Y12 receptor antagonists we have are more predictable, have a faster onset of action, and are more potent. Clearly advantages in the vast majority of our ACS patients. Ticagrelor is the only P2Y12 receptor antagonist to reduce cardiovascular and all-cause mortality in ACS patients managed across the spectrum, including those medically managed with PCI and stent implantation, and with bypass